to the
This
demo.
was really good. Isn't this a wonderful way of looking at a mechanical prosthetic valve with the help of echocardiography? Obviously, this is a 3D image, but Jutta, do we actually need 3D?
Well, thank you, Thomas. Well, such images are very nice, and we will show you more of this in future courses. But of course, 2D echo is still the bread and butter. As you will see in this chapter, you can diagnose dysfunction even without 3D.
Yes, I completely agree. Of course, patients with prosthetic dysfunction can present with very severe problems. And it is important that we also cover this topic in our basic echo course, because I think you will encounter these problems, especially since more and more patients actually have prosthetic valves.
Oh, and you will definitely encounter prosthetic valves if you perform echo. Why? Because so many are implanted now. Let's take a look at the statistics. I mean, heart valves have been implanted since 50 years. And since 2002, when Crébier in France started, 75,000 TAVIs have been implanted per year.
Yes, and there's actually an increase in the implantation rates, especially with biological valves and TAVIs. And remember from our chapter on aortic stenosis that this is a pathology that's also increasing. It's on the rise because we have more and more elderly patients.
Well, valve implantation has certainly been one of the major advances in cardiology, but it does come as a trade-off.
Yes, we're not really healing the patient, but rather replacing one evil with another. It's like casting out the devil with the Beelzebub, because prosthetic valves also carry a risk.
Yes, but let's pin down our first key message of this chapter. Prosthetic valves carry a risk for complications.
But what are the risks, Jutta?
Well, there are many risks, actually. There is bleeding, there is embolism, there is leakage or regurgitation, there's endocarditis, there's obstruction, and finally there's structural failure.
Yeah, and we'll go through each one of these. Let's start with the problem of bleeding.
Well, the risk of bleeding under warfarin really depends on several factors. You all are aware of the has-bled score, which was described in the recent atrial fibrillation guidelines. And there are associated problems such as hypertension, abnormal renal or liver function, and in elderly patients, or if there is drugs or alcohol abuse, and if the INR is difficult to control, the risk can be anywhere from 1.1 to 12.5% per year.
Yes, and that is certainly a very high risk. So bleeding and embolism are actually very strongly related. Too much or too little anticoagulation can either lead to hemorrhage or to embolism.
And embolism is also related to endocarditis, as you will see later on. And the incidence of embolism, it's 0.7 to 1% per year.
Let's talk about the next major complication.
Leakage or regurgitation is an important issue. Actually, now all mechanical valves have a little bit of leakage, which we do not care much about. But of course, we have to think about paravalvular leakage. Well, paravalvular regurgitation occurs in 18 to 48% of mechanical valves. Let's take a look at this 3D image here.
Yeah, you can nicely see that there's a hole right here where the red arrow is. So this is something that, of course, is more than you would like to have, but very small regurgitant jets are something we find quite frequently, and we do not necessarily have to do anything about them. And endocarditis, well, endocarditis is also a major problem. It occurs in very many situations because bacteria simply love the prosthetic material, especially if it's not endothelialized. And since the risk is high, one should always be on the watch out if infection is present or not. And if you have a patient who has a prosthetic valve and infection, I would say always suspect endocarditis, or at least until you have it disproven.
Well, another complication related to anticoagulation also is obstruction. This happens in mechanical valves if patients are not adequately anticoagulated, and it's often combined with embolism too.
And finally, structural failure, which can occur in biological valves, especially because biological valves tend to degenerate over time, and they can cause both obstruction and regurgitation, as you will see. Now, structural failure is much less common in mechanical valves, and actually it doesn't really occur anymore, but it did in the 70s and 80s when a special type of valve was implanted, the so-called convexo-concave valve by Björk Scheile. It was a tilting disc valve, and everything went fine until they modified the design and they changed the architecture of the outlet strut. And then all of a sudden, cases appeared where the strut actually broke and the disc just embolized to all sorts of parts of the bodies. And there was actually over 600 patients where they documented strut fracture. And the problem at that time, of course, was to know who you should explant the valve and who not. So they created all sorts of risk factors to find out who would be at risk or not. But eventually there is still, I think at that time, around 35,000 people who had still the Björk Scheile convexo-concave valve implanted. Certainly something that, is a concern to the patient, right? But we don't see that now anymore, do we?
No, it's quite rare now, but I can remember those dramatic cases at that time.
Yes, of course, many of them led to sudden cardiac death and massive, of course, regurgitation and embolism. So that was a big, big concern. But nowadays, of course, these valves are tested and looked at very, very thoroughly.
So before we turn to echo, I think it is very good if we understand how valves are actually implanted. Here is an example of aortic valve surgery.
Yes, if you look at what is being performed, here we have the moment where the aortic valve is cut out of the aortic root, and then there is a sizing of the aortic annulus so that we know which size of the prosthesis we need, and then sutures are placed basically with little pledges. Those are the little white things we see right here, and that is done all around the entire circumference of the valve. And then once all these sutures are in place, the aortic valve is then positioned and eventually then implanted in this following manner, pressed to the aortic root, and the sutures are eventually then fastened to the aortic root for final fixture of the prosthesis. Now, there are newer ways of aortic valve implantations which are now being developed where you only need 3 stitches, very similar to TAVI, where we use a balloon to expand the aortic root and then use 3 stitches. Here you see in the final part of the operation the closure of the aortic root and the aortic valve is in place. Okay, and now we'll take a closer look on how the echocardiogram looks in prosthetic valves.
And here we have a patient with a prosthetic valve, and the question for you is, can you detect where the prosthesis is and which type it is?
Okay, I'll start from a peristernal long axis view. I think the aortic valve is completely normal. Do you agree, Anna?
Yes, we can assume it's not the problem in the aortic valve, while the mitral valve looks weird somehow. We have 2 structures you are pointing at, which are thick and hyperechoic, while we cannot see the mitral leaflet.
Yes. We'll take a look at the apical view as well, because it's always good to look at prosthetic valves, obviously from more than one view. And just by looking at this 4-chamber view, you can not only tell that it is a mechanical valve, but also which type of mechanical valve it is.
Yet it's a B-leaflet prosthesis, and we can see these 2 dots. Actually, we can also point at them, opening symmetrically and closing, and these are
so each of these dots represents one of the discs, and if you look at the 4-chamber view now with more of the atrium, you see that there's a lot of shadows in the left atrium, which is a bit of a problem with mechanical valves because you have a lot of reverberation artifacts.
Yes, it would be also difficult to assess jets and the dimension of the left atrium, but it's a typical feature of a mechanical prosthesis. So in conclusion, we have a patient with a B-leaflet prosthesis, which is mechanical and in mitral position.
And so this is a close-up of such a mechanical bi-leaflet valve. You see the 2 discs, how they open and close.
Well, here you can actually see how it looks in fluoroscopy. Just look at the discs opening and closing.
Yes, and this is also where you would measure the angles to make sure that there is no obstruction or failure of opening or closing of the prosthesis. So fluoroscopy is also very important in the assessment of these valves.
And from a flow perspective, all these valves are just the same as a normal valve. Well, yes. They come close, but of course you will see some degree of flow acceleration. And there is usually a small gradient across the valve.
Yes, we'll later see how we measure these gradients, because that is a very important part of the examination of prosthetic valves to find out if the gradients are normal or not.
So let us take a look at a prosthetic valve in a different position.
So I want you to focus on the aortic valve. If you look closely, you do not see any normal tissue in the annulus of the aortic valve. As a matter of fact, you have problems to see a valve at all. And then if you tilt a little bit, you will see those structures here, which seem to reverberate. Now you have a wonderful view of the M-mode, and what you see within the aortic root are these reverberations. And this is indicative of a mechanical aortic valve. Now you can also see the mechanical valve from a 5-chamber view. I'll do this right away. Here is the 5-chamber view, and in our patient you actually see the circumference of the prosthetic valve, because the valve is coming towards us and you're cutting it in a short axis. And again, we have these strong artifacts right here. So we've made the diagnosis of a patient who has not only a mechanical mitral valve, but also a mechanical aortic valve. So let's summarize.
Mechanical valves are characterized by artifacts and shadowing distal to the prosthesis. This is also the case for all prosthetic valves, so also for the aortic valve.
Yes, you can see that very nicely here. There's a shadow here in the region of the aortic valve, and one of the problems you have is that sometimes the prosthesis casts a shadow on itself. Here in this peristernal long axis view, we see that there is a shadow here on the entire prosthetic valve, which at times makes it quite difficult to really interpret. In some patients, it's easy to determine the model of the prosthesis, as for example here in this 4-chamber view of a bileaflet mechanical valve. You see the 2 discs right here. Sometimes it's possible to see it also in the aortic position, that it is a bileaflet valve, but in essence I would say it's more difficult in the aortic versus the mitral position. And finally, there is some degree of flow acceleration at the valve.
Yes, there is always some degree of gradient, and we will see later that measuring this gradient will be important to tell if the function of the valve is good. Now, let us turn to another type of valve that you will frequently encounter, the biological valve. It's made either from bovine pericardium or pig.
And here's how a biological prosthesis look. This is a Hancock prosthesis, and the components of the prosthesis are: you would have a ring right here, again a sewing ring where you put the sutures, and then you have 3 struts and a housing on which the biological tissue is kind of fixed or tailored, and the valve has 3 cusps similar to the aortic valve, which can open and close depending on the blood flow. So if you maybe turn this around, you can see that it has truly 3 cusps, 1, 2, and 3, and actually looks like an aortic valve. Still, you can implant it both into the mitral and into the aortic position. And with echo, you will recognize the valve because it has these 3 struts.
Here is an example of what you would see if it is implanted in a mitral position. The typical features are that of the struts with tissue in between. One will usually only see 2 struts. And in color Doppler, one sees turbulent flow, similar to mitral stenosis. But of course, the velocities are not as high unless there is really a stenosis.
And here's an example of an aortic bioprosthesis where you can see the 3 struts and the ring of the prosthesis. Now, like I said, it's sometimes very difficult to really appreciate the prosthetic valve, and sometimes you might even miss it. I always tell my students, if you want to know if the patient has a prosthesis or not, look at his chest, because you should have a thoracotomy, a scar, unless, of course, the patient has a TAVI. But the TAVI valves are actually more easy to see than, for example, such biological valves. Here is another type of prosthetic valve, a so-called TAVI valve. TAVI is a procedure where you implant the valves via a catheter. And the nice thing here is that you can put this valve onto a frame which is made out of nitinol, and you can kind of compress it in such a way that it actually fits into a catheter. And then you expand it when you're at the position of the aortic valve and retrieve the catheter, and the valve would then be in place with this part actually being in the aortic root, and this would be where the aortic valve is. Now, this is made out of porcine pericardium. It's lasered out of the tissue and then kind of stitched with over 1,200 stitches. It takes about 20 hours to manufacture such a prosthesis, and it's a truly amazing valve. Of course, it's not the only model available for TAVI. There's also balloon expandable ones, and all sorts of new models are coming out of the market, but it's certainly a revolution in the way aortic valves are implanted, and you'll be seeing more and more of these valves in the future. On the echocardiogram, these valves look a little bit different than conventional bioprosthetic valves because they extend relatively far into the LVOT, as you can see right here. So since they're stented valves, you have more, I would say, metallic material, and therefore they're easier to see, and like I said, they extend further into the LVOT.
So for the sake of mentioning, there are many different models and valves out there, such as the stentless valves, the homografts, and the valved grafts. We would go into these, but they will be covered further in the masterclass.
Okay, let us summarize. Our key message there is there are biological valves and mechanical valves. Those are the big two categories, I would say.